And hopefully nobody shouts any obscenities in the background. All right, so real quick show of hands, how many people plan on going on to be paramedics at any point in your career? Like, have you had that thought? I say show of hands, that's kind of dumb. Yeah, I was about to say it. You can type it if you want to. Either way, we're just talking at the moment. Okay, so I got 1, 2, 3, 4, 5, 6. Somebody said it, 7. So a lot of y'all. All right, that's good because EMT is the basis for everything, but it's not. It's definitely not the highest paying, and it's very limited in what you can do. This is a lot of places. This is the minimum. All right. This is also the minimum for being an advanced, being a paramedic. They require that you be an EMT in the first place. However, uh, if EMS is your goal, then this should not be your finish line. In tonight's chapter, what we're going to be going over is something that may seem a little out of the scope for an EMT, but the concepts that we're going to talk about are rock solid, and this is what's going to help you understand how the medications that we give work on the body. This is more of a science lesson about that than it is about the actual medications. We will talk about the specific ones, like I think we're going to have Narcan in here. I'm sure we'll have Epi for the EpiPen and albuterol and all that stuff. But there's going to be a big chunk of this lecture that is about what an alpha agonist means, what a beta blocker, a beta agonist, that kind of stuff. The reason I asked about who's going on to paramedic is because pharmacology is usually, if anybody's going to fail out of paramedic school, it's that chapter. Some programs will put everything you ever need to know about pharmacology into that one chapter. And you talk about information overload, that's it. I would love for you guys to come into our class when we get it up and running for into next year, because we're not going to do it that way. We're going to have you learn the cardiac drugs when you go into cardiology, the airway drugs when you go into airway, and that kind of thing. But that even with that, that's kind of a tough chapter. All right. And so the stuff that we're going to talk about tonight, if you can get this and get it now, even though what beta 1 and beta 2 differences are, is not going to really help you at the bottom line as an EMT. But if you're going to try to move on, this is the basis that will make that chapter much less painful when you get to it. All right, so medications are an important intervention available to you as an EMT, even though you don't have that much. What you do have is pretty important. They give you the critical stuff, and even if you can't directly stab your patient with it and inject it into them, or like IV or whatever, helping them set it up, helping understand this stuff will help the paramedics get the information or get the medication in. And it'll also help you catch mistakes before they happen, right? Because a lot of the meds that a paramedic gives are given through an IV, or they're breathed in through a nebulizer. And once those things go in, you can't take them back. So this is where you really get to help the levels above you, even if you don't want to become a paramedic. This is good information to have, because we're all human. And the paramedics got to get up at 2 o'clock in the morning for these calls, just like you do. So they may be, sitting there struggling with med calculations and all that stuff. And we're not going to go too much into the math that you're in, but there are some basic things that if your paramedic misses it and you see it happen, you're like, wait a minute, I don't know what it's supposed to be, but I know it's not supposed to be that. And you can stop them and stop a mistake before it happens. If we use medication appropriately, you can alleviate pain, you can fix a patient's condition, at least improve them or stabilize them. Some medications will straight up fix somebody. So like if we show up to a diabetic emergency, and this happens a lot, type 2 diabetics or even type 1 diabetics, if they don't eat right, or if they mess up their insulin, they kind of screw themselves out of having enough blood sugar to operate as a human being. So we show up to these kind of calls. And even as an EMT, so one of the medications you can give is oral glucose. So as long as they're awake, you can give this to them. And there's some alternatives that taste a lot better, and we'll talk about that when we get to this portion. But that's an intervention that you can give and then get a refusal, because they don't need to go to the hospital. It was just a mistake they made, and you brought them back to their right mind. So that's fantastic. Other medications really don't have that good of an outcome. Right? If you're giving somebody nitros, well, they do still need to go to the doctor or to the ER. If you're giving somebody oxygen, it's not a big deal. That usually doesn't fix a lot of conditions. They still have the underlying condition, but it fixes a symptom. So the different medications that you get will go to different lengths with your patients, but they're all very beneficial. The only stuff that really sucks that's out there right now, and we're going to talk about it, but you really don't see it in the system anymore, so they're probably going to pull it from the curriculum soon, would be things like activated charcoal. We used to give that for overdoses, but the problem is it's ingested. So, I mean, if we go to a patient that ingested 15 to 20 different pills 20 minutes ago, and then you give them activated charcoal, what is that going to do for them? It's never going to catch up to what they ingested, so it really doesn't do anything. And then there are some medications that activated charcoal won't mess with anyway. So like if they drank bleach, what is that? What's that going to do? So some medications are going away. What's up? Ooh, I got two systems too close to each other. Let me mute. I'm going to mute you, but if you needed to say something, just unmute and say it. All right. Otherwise, going to get back on it. So as an EMT, you're going to administer medications. Now that's where you do it yourself, right? You can give this medication to somebody, they don't have to put their hands on it. You just say open wide and say ah and whatever. You may help patients self-administer medications. You can ask patients about medication use and allergies. A lot of times, when we talked about your sample history, that kind of thing. It's not just about what you can give, it's understanding what they take, because that's going to alter sometimes what they take already before you ever show up on the scene is going to change everything you do with that patient. An example of that would be if you show up to let's say a late 50-year-old guy that's in his house is complaining of chest pains. Well, a lot of our interventions are dependent on what medications he's already taken. So if he's already taken all his aspirin, we're not going to give him aspirin for one thing. Let's say he took Viagra to have a nice night with his wife or whatever, and that could be what maybe or maybe not caused his heart issue. We can't help him with nitros. We don't want him to take them because those two meds work synergistically with each other. And even though he might have a decent blood pressure, if he's got that medication in his system, and we'll harp on this when we get to nitro, but we really don't want to give it to him because it's going to amplify the blood pressure drop. And then you may wind up doing CPR on a patient that otherwise would have just rode silently with you to the hospital. So it's important to understand that kind of stuff, and that's what we're really going to harp on tonight. If you don't get the meds specifically, I'm okay with that, because when we get to cardiology, we're going to talk more about nitro administration and use and epi for the allergic reactions, so on and so on. But for now, I want you to kind of get the science behind them and how they work. All right, so let's start off with how medications work. Pharmacology as a term is just the science of drugs. So pharmacist, pharmacy tech, so on, it's all the same. They all deal with the drugs. If you're friends with a pharmacist, congratulations, you know a drug dealer. A medication is a substance used to treat or prevent disease or relieve pain. And then pharmacodynamics is a process by which medications work on the body. These are important terms to think about when we go into this chapter. If you hear me start to talk about them or whatever, just know the difference. That's all. The way that medication works on the body is by different receptors. All right, so we didn't really touch on this too much when we talked about anatomy, but when we talked about the neurological part and the endocrine system, think about that. So your neurologic system is just on and off, right? It's electricity. It's either 100% there or 100% not. But that's not how our bodies work. Our bodies operate in different shades of gray, right? So we have the endocrine system, which when they get hit by those electrical impulses, for however long they're getting hit by it, they're going to release substances, and the body picks up those substances by chemical receptors that are set to pick them up like a puzzle piece. So if the chemical fits a receptor, it's going to bind to it, and your body's going to get that reaction from it. If the receptor and the chemical don't match, or if the receptor's already got something there, which is important when we start talking about things like Narcan, then that chemical is just going to pass by and nothing's going to happen. All right. So keep that in mind when we're talking about how these drugs operate on the body. As the body breaks them down, this stuff gets into your bloodstream and it continues to float until it's eventually either A, filtered out by the liver, or B, it gets used by the body and then discarded as waste. Um, a medication can either increase or decrease the normal function of the body. So we have two terms. We have agonist and antagonist. An agonist medication is something that stimulates a receptor. So for example, if we give epi, somebody tell me what you think what happens to a patient when we give them epi. I swore I pulled up
They
epi.
have anaphylaxis.
Well, think about it from their vital signs. So, okay, Donna got it. Increased heart rate. You hit somebody with epi, there's another name for epi. If it's made in a lab, we call it epinephrine. If it's made in your body, we call it adrenaline. All right, it's pretty much the same thing. So all epi is a synthetic adrenaline. Therefore, if we hit somebody with it, they're going to get the effects of having an adrenaline shot in their system. They're going to see an increased heart rate, and there's some other vital signs that will change, and we'll talk about that, especially when we start talking about allergic reactions. Um, and what our goal is when we hit somebody with epi is not always to increase the heart rate, but that's an example of an agonist. You give somebody this medication and it causes a stimulation when it gets connected to their receptors. And then we have antagonists. Antagonist binds to a receptor and blocks other medications or chemicals. A good example of that would be Narcan. Let's say you show up to a patient's house and they have either intentionally or accidentally they've overdosed on something like, say, fentanyl. All right. You give the Narcan, whatever route you're allowed to do it. Usually EMTs do it intranasally, which means it's up the nose, but you give them Narcan. Now they have fentanyl going around in their system, binding to different receptors and stuff like that, and that's causing them to have that overdosing reaction that they've got. But Narcan is a substance that is designed to be more attractive to the same receptors that that opioids are. So it competes, right? If a receptor sees two different things that it can bond with, it's going to bond with the one that attracts the most. And Narcan or naloxone or whatever trade name you want to use, um, is more attracted to those same receptors. So it gets in the way. It bonds. It doesn't have the same drowsy effect. All it does is it just ties up that receptor, and then that receptor can no longer bond with the opioid that's floating around in their system. So that's an example of an antagonist, and we'll talk more about Narcan when we get to that point, because there's some things I want you guys to know about that. Narcan's pretty easy. Doesn't really affect your patient in a bad way, but if you there, I got some horror stories for you, so just be careful about that. We'll get to that point. And then another term I want you to know is dose. So the dose is the amount of the medication that's given, and this is usually when you're dealing with an adult. Most dosages, especially with what you'll deal with as an EMT, are going to be set in stone. So, if you're going to give epi for an allergic reaction, you're going to give a set amount. If you're going to give nitros or aspirin, you're going to give a set amount. When we deal with kids, that's a little bit different. Kid dosages are weight based, and that's where, again, you kind of get out of you won't be doing the med calculations as EMTs, but as you go through your career, even if you don't go on the paramedic school, if you can take the time to advance your training and learn those medication or those med administration calculations, you could save somebody's life or help your paramedic not make a mistake just by being a check. Because paramedics are supposed to do the calculations and then slide it to their partner and say, does this look right, before they ever give a med. That's what they're taught. And in reality, the only person in front of them may be an EMT who is completely clueless on what the med's supposed to be. So do yourself a favor, definitely do your paramedic a favor, and do your patient a favor. When you get some time, learn these things. All right. Now the action of a medication, this is what it does. All right. So when we give Tylenol, what are we giving Tylenol for? This is just an example. Okay. So fever, pain in general. Good. I'm glad nobody said headache. All right. So you're providing relief to a symptom. All right. It's not just a headache. It's that particular pain. Same thing with the other stuff. They now, granted, they work in a different way. Um, say ibuprofen from acetaminophen. It's just two different medications that operate in different ways, but they all have the same action in the long run. It's a therapeutic effect of what that medication is there for. And those are analgesics. They're supposed to relieve pain. Um, the therapeutic of effect is exactly what we expect the medication to have on the body. That's the primary thing. Anything else is a side effect. All right. So, for example, um, we'll go with nitro. Nitro is an easy one. The therapeutic or the action of nitro is to reduce preload on the heart, really, and cause a smooth muscle relaxant. Um, a side effect of that is actually relieving the pain. Nitros we give it for that reason, but that's not exactly what it does. The action is what it's doing on the body. The pain relief is what comes from that. Another example that would probably make this a little bit clearer, when we mentioned Viagra earlier. Anybody knows what Viagra was originally planned to be? Anybody know? Okay, so a vasodilator, for what reason? What were they originally trying to market Viagra for? Heart med, Justin, you're pretty close. Y'all are hitting around it. So, in easy terms, Viagra was
Cardiovascular
originally
problem.
intended to be, sorry, there you go. Justin got it. All right. Viagra was
Cardiovascular.
blood pressure. So Viagra was originally intended to be a treatment for hypertension. It was supposed to be able to lower people's blood pressure, and that's what it was going to be used for. But when they were going through the clinical trials, they found out that all the patients were getting erectile dysfunction at the time.
No.
I got you. Hold on. There we go. All right. So anyway, they found that the pharmaceutical company that makes Viagra found out that they could make a lot more money if they sold it as a male enhancement drug. So they changed the purpose of the drug to to be marketed for that. All they had to do was just change their marketing scheme. But it was a hypertension drug, and it works really well. It's just not what it's sold for. So a couple other words that we need to know, and these are going to be you're going to hear these a lot. Indications and contraindications. An indication is a reason or condition where you would give a medicine. So if you have a headache, take Tylenol. That's an indication. Um, if you have chest pain, but your blood pressure is rocking at like 80 systolic, um, that's a contraindication for something like nitro. You have to have a blood pressure above 100 to give a nitro. So if they don't, then the blood pressure becomes a contraindication. Other contraindications that you're going to typically see are going to be something along the lines of like hypersensitivity, um, allergic reactions, allergy to iodine, allergy to eggs. Things like that. If you ever see patients that have that, some medications are contraindicated for those things because it could flare up an allergic reaction or much worse. Like I said, you don't want to wind up doing CPR on a guy that just had chest pains a little while ago. Contraindications, like it says on your slide, you have some that are absolute, some that are relative. All right, absolute contraindications, these are situations in which a medication should never be given by any circumstance. All right. And then you have relative contraindications. These are more like it may not work out in their favor. It could do some harm if you give it to them, but if you can at least document where not giving it was worse than giving it and dealing with the repercussions, then you're okay typically. Some medications, an example would be glucose. A contraindication for glucose is hyperglycemia. If their blood sugar is too high, we don't give them more, as we don't want to do that. However, That's a relative contraindication because what if your glucometer is dead and you don't know what their glucose is? It actually takes a lot longer for the body to suffer from hyperglycemia than it does from hypoglycemia. So if you're in the field, you think somebody's having a diabetic emergency and you don't have a number on them, you can give oral glucose if they're awake. And if they are hypoglycemic, then great, you fix them. If they're hyperglycemic, then okay, we essentially might have made the matter worse. However, the effect of that contraindication is going to take a while. Hopefully, they're going to be at the hospital by then. So you let them know. We're like, hey, we couldn't get a glucometer. We couldn't get a number. So we went ahead and gave oral glucose, and then the hospital can give them insulin if they need to bring it down because they'll be able to get a number. So that's the difference there. Side effects. Side effects are funny. I had a friend that was going through pharmacy school a couple years back, and he was telling me how they determine side effects at the FDA. When they start doing human trials, um, everybody goes home and they start monitoring them for X amount of time. I think it's like 6 months or something. And everything any deviation from your baseline vital signs, any sickness, anything adverse that happens to you while you're in that trial gets listed as a side effect. So when you watch these commercials on TV and you see, for example, side effects may include, and they got so many things that are flying through there, it's because they have to list everything that somebody had during the trial because they don't know. All right, we don't watch people that long. I mean, even though it takes usually about 10 years to get a medication through, that particular portion of it usually doesn't last the full 10 years. There's other things that go into it. So you could have a side effect of stubbed toe, or stomach aches, stomach cramps, chest pains, hypertension. All these things may only have been like one or two people that had it, and it could have been for something completely unrelated. But because of the way it's all written up, it gets listed. At least, especially, I would say, especially on the drugs you see marketed on TV. Now, side effects in general, these are just their effects other than what we expect to happen. So, other than the action. And these can be unintended or untoward. Sometimes they work out in your favor. Like you can give a medication because you know a side effect is going to happen, and that's what you want. An example of that would be one of our paramedics at the Navy base that I last worked at had a patient that was choking, and I forget what the reason was, but for whatever reason, he could not do. It was going to be medically worse to do the Heimlich maneuver to this guy than it would have been to not do it. So he had to get the food out. So he took some nitro spray, sprayed it in the guy's mouth. It's a smooth muscle relaxant, and it actually caused his esophagus to dilate, and then the food fell through. So he didn't. He relieved the patient of choking without doing the Heimlich, and he used a cardiac med because he knew what the side effect was going to be. He knew what was going to happen when he put it in this guy's mouth. Um, you got to be careful with that. He is really good at what he does. He took a chance, but that's not. I don't recommend that. I'm just saying that that's an example of how side effects can be used to your advantage sometimes. Okay, medication names. The generic name is a simple, clear, non-proprietary name. An example of that's ibuprofen, right? Ibuprofen is just a basic name. The trade name is the manufacturer's brand name. So Tylenol. Anybody know what the real name for Tylenol is? See if you spell it right. Say what?
Acetaminophen.
Acetaminophen. I dare somebody to spell that without Googling it. Somebody besides Tylenol. I should have known you'd get it. But anyway, yeah. So acetaminophen is a generic name for Tylenol. Any company can use acetaminophen to name that drug if they make it, because there's more than one drug company out there that does. Same thing with ibuprofen. Um, Now each individual company gets to name it what they want to. So, oh, did spell check catch it? Nice. Um, an example of that would be, Tylenol is on the slide for acetaminophen, but you have what's the Aleve. All right, Aleve is a trade name for naproxen. Naproxen would have been that drug's generic name. Prescription drugs are distributed only by pharmacists and require a physician to order. A good example being your antibiotics. We don't sell antibiotics over the counter, mainly because we don't want the virus or the bacteria that's out there getting resistant to it, if at all possible. Usually, you will find some medications like there's Motrin that's over the counter, and then there's Motrin that's um, prescription only, right? What's the difference? Yeah, Aleve and naproxen is the same drug. They're just different names for it. I know naproxen is usually like if you're going to get a prescription, you're going to get it for naproxen because that's a generic name. But it is Aleve, so you could technically instead of spending the money on well for pain meds, for example, instead of spending the money on the prescription strength, you can just say, for example, like ibuprofen. Prescription strength ibuprofen, 800 milligrams. Can't buy it at that dose over the counter, but you can buy a regular bottle of ibuprofen and 200 milligrams to take 4 of them, get the same thing. There are some differences. Like, for example, there's Tylenol with codeine. Codeine is prescription only to my knowledge. So there may be some meds that don't have an over-the-counter equivalent. I use naproxen for distance running. I use naproxen because I'm 37 years old and have arthritis in my hands. So it works. And it really works because the pain has been gone. I think I might finally be kicked of having those problems with my joints. I'm just getting old. Anyway, other kinds of drugs, recreational drugs. All right, so heroin and cocaine. We have herbal remedies, enhancement drugs, vitamin supplements. Some of the calls you may get will be to a gym because somebody took the wrong pre-workout. I may or may not be guilty of that one. We had a problem. Well, it wasn't a problem, but it was a problem for me. A buddy of mine wanted me to try this new pre-workout of his, so he gives me. I didn't watch him make it, but he gave me a shaker cup full of it, and I drank it. And I think I worked out for like 3 hours straight with him lifting heavier than I'd ever lifted. Then I got on the treadmill and ran twice my normal distance, then got off the treadmill, and then went and played basketball, and then got done with that and went back and lifted some more weights. And I got done with that, and I decided to go for a walk around the neighborhood. And he was just like, "This stuff is awesome. I don't know what it is, but I want it." And he told me, so I ordered it. And then I made a mistake. I didn't ask him how much of that pre-workout he gave me. I thought he gave me a full scoop. Turns out he only gave me a quarter. So I take my first full scoop of it, go to the gym. Before I walk in, I'm already starting to break out. My skin's turning red. I'm tachycardic. My heart's about to beat itself out of my throat. Um, I get one move done, and I start to feel nauseous. um, I think I stayed in the locker room of the gym for a good 45 minutes before I felt confident that I could make it to my truck without throwing up. And then I finally get back to my house, I crawl up the stairs. I'm so wired. I'm not tired. It's just I was almost inebriated from this stuff. I lay down on the floor of my bedroom, and it's almost like listening to people whisper 6 blocks away. And I stayed there in this weird comatose state for about 4.5 to 5 hours, waiting on this stuff to wear off of me, so that I could get up and drink some water or whatever. I went hot flashes. Really probably should have called 911. But my point being is that you're going to get people that do call 911 because they take too much pre-workout, or they take a new one and they do actually have an allergy to it that they didn't know about before, and that kind of thing. So you may see, you may respond to some pretty interesting calls that are technically drug overdoses, but they're not the drugs like we would think, right? So there's a story for you. Yeah, I found out after the fact that he only gave me a quarter of a scoop, and I have never. I gave him my thing. I was like, I don't want it. I think that's the closest I came to witnessing my own death. I'm pretty good. All right. couple other terms. So let's talk about routes of administration. We have intraoral and parenteral. Intraoral medications enter the body through the digestive system. That can be any form. All right, you drink cough syrup, you swallow a pill, you put a nitro spray in somebody's mouth, you put a tablet in there that dissolves. They don't even have to swallow it; they just have to go into the mouth. That is enteral medications. Parenteral medications enter the body by some other means. So suppositories, um, IVs, anything that's injected, that kind of thing. Those are going to be your parenteral ones. And Sharon, you can have it. I don't know. So anybody that's interested, it's called steel supplements. Steel like the metal. It is very, very potent. It definitely does what they say it does. Absorption is a process by which medications travel through the body tissues to the bloodstream. So there are topical ointments out there. There's fentanyl patches, there's nicotine patches, that kind of thing, and those enter the body through absorption. Okay. Common routes of administration, you have PR, which is by rectum. We usually use this in kids, especially if they are at high risk of vomiting. We don't want to give them a medication, have them throw it up 5 minutes later, and then they don't get the use of the medication. So um, a lot of times we will use those. PO is by mouth. That's pretty much everything else. Anything you're going to swallow, it enters the bloodstream through the digestive system, and it takes a little bit longer for symptoms or for it to take effect. So if we give you Benadryl by mouth, we expect your histamine response to slow down and stop in about half an hour. That's when you're going to start to see that. If we give you Benadryl by IV, we're talking like 30 seconds. So that's an example, right? Because IV, we're going straight to the bloodstream. If you swallow it, it's got to be digested. Then it's got to get into your portal vessels and go through the liver, and it has to get processed by the liver, and it goes from there to the bloodstream, and it just continues to rotate through, hits the liver again, goes back into circulation, hits the liver again, goes back into circulation, and the liver breaks it down a little bit every time. Um, which we'll talk more about that in a little bit. All right. So the good thing about doing administration by mouth or by rectum is it is non-invasive. We're not breaking the skin. It's less expensive. It takes a little bit longer to take effect. So if you do make a mistake, you can correct it, right? If let's say you give somebody something, they swallow it, and you like 2 minutes later, you're like, ah, crap, that was the wrong med. You can give them activated charcoal. At that particular instance, it would probably work. But the reason we don't carry it is because that's like 1 in a million chance. Usually it's because somebody took something 45 minutes ago and they called 911 once the symptoms started, and charcoal is not going to do anything for you. But it's also the biggest thing is non-invasive, which means that you as an EMT can typically do this. All right. Anything invasive tends to be out of your scope. The cons for it, unpredictable absorption rates. It may the average time it takes somebody to absorb and start to see the therapeutic effect of anything by mouth, it's about 30 to 45 minutes. You take Tylenol, if your headache leaves faster than that, it was either already on the way out or a what's the term? Where you think you get something but you don't, like a fake medicine. Um, yeah, it's a response like that. Otherwise, if it's a persistent headache, usually 30 to 45 minutes later, that's when you're going to start to see that medicine take effect on it. Some people just have a stupidly fast metabolism. A buddy of mine lives in New York. You give him Tylenol, 10 minutes later, it's affecting him. But the therapeutic time is like stupidly short. 30 minutes into it, it's already out of his system. And that's an issue for him because like he had to go to surgery and he kept the anesthesiologist on his toes because as fast as they were giving him the anesthesia, it was wearing off. He kept bucking the tube, trying to come out of it and everything. And they're like, I'm going to run out of anesthesia before this guy's done with surgery. All right. Some other common routes of administration. We have IV, which is into the vein, IO, which is into the bone. If you guys go to become advanced EMTs, you're going to learn to give medications that route. As basics, you're not going to do it. Subcutaneous is beneath the skin. If anybody's ever had a TB skin test, that's what that is. And then an intramuscular injection, your flu shots are like that, where you're not aiming for a vessel or anything. You're just stabbing somebody in the muscle, pushing the medicine, and it's going to chill out there. And each one of these routes has a various time for how long it takes to take effect. Can I pronounce IO? Oh, yeah, I just did. IO. Oh, you want me to say the word? Yeah, okay. Intraosseous is how you say it. That's a weird word. I agree. But that just means under the bone. And those, um, they honestly, they don't hurt any worse really than a needle. You would think they'd be excruciating, but they're not. The worst pain about it is when they flush the tube and then they start trying to push meds in because you really don't have that much space in your bone cavity. But the needle itself doesn't hurt. Um, the thing about IO, that is a pretty good alternative to an IV. They're actually teaching paramedics now. If you can't get the IV on 2 sticks, just go straight to an IO. And depending on how bad your patient is, a lot of times they won't even bother with an IV, especially in kids in cardiac arrests. A lot of times your paramedics are going straight to the IO because when your blood pressure flattens out, so do your veins, and it becomes that much harder to get an IV stick. And if you're in a real big rush to get meds or fluid in, if an IO is within your scope, then just do it. I mean, if they're unconscious, they're not going to feel anything anyway. Um, and like I said, even then, the pain really isn't. It's on par with an IV, so it's really not that bad. It just looks painful. Um, let's see, were we on the right slide? All right. Sub Q, like I was talking about, this is beneath the skin. It's really just kind of into the fatty tissue of the skin itself. You're not going all the way to the muscle. We don't give a lot of meds in this section, but the big common thing that everybody remembers for sub Q is the TB skin test, where they just inject it in. You got the little bubble on your arm, and then you go back 3 days later and test it. Um, there's less blood tissue in those tissues, so it takes a little bit longer for the medication to be absorbed. It's longer lasting, but it's also a slower onset. Insulin injections are a sub Q. Some forms of epi, but nothing that I can consciously recall giving has ever been sub Q for epi. IM injections, this is into the muscle. Again, your flu shots. Um, if you're going to get any kind of hormone therapy, typically a lot of times, like I think testosterone injections go into the muscle. Um, those are or like your booster shots for kids in the arm, that kind of thing. These are usually absorbed pretty quick, not as fast as say like an IV, but they are pretty fast. Not all medications can be administered by the IM route. So EpiPens, Mark 1 auto injectors, those are all going intramuscular. Some possible problems are going to be damage to the muscle tissue, uneven or unreliable absorption, and depending on how much you give it or how deep you go, when you withdraw the needle, I've actually seen the medication come right back out the hole in the skin. So some medication may be lost if you don't do it right, or even if you're doing it right, if you're giving too much for the depth that you're at, some of it will come back out. Inhalation, these are breathed into the lungs, usually through vaporized like nebulizers or something like that. If somebody's having an asthma attack and they can still get air into their lungs, a medication that's usually given is albuterol. Paramedics will use a liquid albuterol and put it into a nebulizer and have the patient breathe it. Patients with known asthma will use inhalers, and that's what we're going to talk about tonight when we get to this portion. All right, this usually gets into the blood pretty quickly because as soon as it gets into your lungs, it gets picked up by your pulmonary circulation and it goes into the bloodstream. So it's pretty fast. So this minimizes the effects of the medication in other body tissues. Some forms could be aerosols, fine powders, sprays. Not everything goes into the lungs. An example of intranasal that does not go to the lungs would be Narcan. That actually, or anything that is done through those little atomizers, those actually get absorbed by the bloodstream in your nasal cavity. You're not actually inhaling that stuff. The flu spray is another one if anybody's ever had that instead of the shot. Sublingual is under the tongue. We give some forms of nitro that way. Enters the oral mucosa under the tongue and is absorbed into the bloodstream within minutes. There's a lot of vascularity under the tongue, under this or inside of the cheeks, that kind of thing. This is faster than the oral route because it's getting absorbed by the bloodstream. It's not being digested. Let's see, transcutaneous is on this slide. All right, so this is through the skin. Anything trans means through or across. So through the skin, supplied as a patch. We do give some nitros like that. You guys typically won't as EMTs, but we nitro paste, paramedics will use. Depending on where you go, you can give it that way. Some EMTs will give it with nitro paste, but for the most part, because we're just helping our patient take it, it usually winds up being the pill. Fentanyl patches, nicotine patches are examples of these, nitroglycerin patches. Intranasal, this is where, again, it's absorbed into the bloodstream. It goes in through the nose, but it's not inhaled. So your Narcan is up there, flu vaccine. There's just a table of everything we talked about. But notice the rate rather. Sublingual, per rectum, these are rapid because, again, they're quickly absorbed into the bloodstream. By mouth is slow because now you're going through the actual digestive tract, and that takes for freaking ever, especially if it's pain meds. It's never fast enough. IV and IO is immediate because you're a direct line straight to the bloodstream. Inhalation and intranasal is pretty fast. And then sub-Q and transcutaneous is fast again because the absorption is slow. All right, medication forms. This is basically the physical form your medication is. So it could be a pill, could be a liquid, could be a spray. And the type of form, that should go without saying, but the type of form dictates the route of administration. You can't shove a pill through an IV port. Please don't try. The manufacturer chooses the form to ensure proper route of administration, the timing of the medication's release into the bloodstream, and the effects on the target organs or body systems. A good example being epi. So we have a couple different forms of epi. All right. If you're going to inject epi directly into somebody's bloodstream, like a paramedic would do during a cardiac arrest, we give it in a 1 to 1,000 dose. It's just a little bit more watered down. We want that lower amount because there's no filter, there's no buffer. The body has no way of breaking this down between the route of entry and going straight to the heart and everything. So the medication is itself a little bit watered down. If we're going to give epi for an allergic reaction and we're using it in, say, like an EpiPen or just any other kind of IM injection, then we use I may have said that backwards. It's 1 to 10,000 if we're going to go into the bloodstream directly. It's 1 to 1,000, 10 times more potent, a little bit more, not 10 times less diluted. If we're going to go into the muscle, because some of it is absorbed, some of it doesn't get through the absorption process, and so it kind of dumbs the medication down. If we were to inject somebody IM with 1 to 10,000, they may not get anywhere near the effect, if any at all, based on what we give them. So that's kind of where they're going at with this. If they want something to be time release, they're not going to make it in an IV form because it's such an instant route. All right, time release, anything they want to last a while, it's typically going to be taken by mouth because it takes a long time for the digestive tract to get that through. All right. Basic medication forms, we have tablets and capsules, solutions and suspensions. A suspension is any powder that you mix in a fluid. Activated charcoal is a suspension. Metered dose inhalers, or MDIs, topical medications, transcutaneous medications, gels, and gases for inhalation. All right, so let's talk about capsules for a second. Most medications given by mouth are in this form. So you just swallow it whole, unless there's a specific reason you want them to chew it, like aspirin. Capsules are gelatin shells with powder or a liquid medication. Tablets often contain other materials that are mixed with the medication and compressed. So you can, like, Tylenol, for example, or here's an even better example. I'm doing keto to try to lose some belly fat and then not fail my PT test again. But with that comes a major electrolyte imbalance, and I'm just a giant walking Charlie horse the last couple of weeks. So I started taking these supplements to get my electrolytes back up. And one, I see you, Wesley. One of the first pill bottle I got was compressed powder. It was horrible. It was like they must have used the cheapest people out there to do it. It was coming apart, flaking apart inside the bottle. I gagged and choked on probably 80% of the pills I tried to eat or swallow out of that bottle. Um, it was just horribly done. Not all of them are like that. Some of them go down fine. A lot of your actual medications like Tylenol that are compressed powders and everything, it's not that way. But these were so bad that I'd pull them out of the bottle and they would start to crumble in my hand. Um, so they obviously they didn't go down very well. Some of them float, which is a problem when you're trying to swallow them down. Um, so not all of them are very easy to swallow. Keep that in mind. Your patient, if you give them a pill, maybe don't stand directly in front of them because if they do gag on it, it's going to go whatever direction they're facing. Solutions and suspensions. A solution is a liquid mixture of one or more substances that cannot be separated simply. All right, so cough syrup is a solution and that kind of thing. Solutions can be given by almost any route. You can drink it, you can inject it. It's just a liquid. So any liquid route, you can put this in. When given by mouth, solutions may be absorbed from the stomach fairly quickly just because they're already broken down into liquids. Many solutions can be given as an IV, IM, or sub-Q injection. So that being said, when you're, 1 o'clock in the morning and you can't really see straight, make sure the vial you're looking at is meant for the route that you're going to want to go. We'll talk about the 5 rights in a little while. A suspension is a mixture of finely ground particles that are distributed evenly throughout a liquid by shaking or stirring, but do not dissolve. An example of that would be salt, right? Like I said, as far as medications go, the easy one is activated charcoal, but you can look at it like salt. Salt doesn't actually get dissolved. It floats in the water. If you boil the water, you're going to find all the salt still in the bottom of the pot. It's important to shake or swirl the suspension before administration because the stuff will settle to the bottom. And it's usually administered by mouth. Um, we really don't give suspensions in any other form, at least not usually, simply because you too much of a risk of clogging a tube up. But occasionally we can give it in other ways. Give it rectally. You can put it directly to the skin, like a calamine lotion. And we do sometimes use IM, so we can inject it into the muscle. Hormone shots and vaccinations are examples of that. Metered dose inhalers, you guys are going to be familiar with how to use these as EMTs, both like you see it in the picture and also with a spacer. This is how we treat asthma attacks. This is how we treat bronchospasms, things of that sort, especially if your patient already has these. A lot of times we don't really carry these ourselves. These will be for known asthmatics who are already diagnosed, already given their medication. So these are liquid or solid. Sometimes it's a powder that's broken into small enough droplets or particles that may be inhaled. A metered dose inhaler directs such substances through mouth into the lungs and delivers the same amount each time, every time they squeeze it. We will talk about how to actually give these doses later. We're not really going over it right now. We're just kind of introducing you to what all's out there. Topical medications. These are your lotions like calamine lotion, cream, ointments, burn ointments. These are, those kind of things that you would put on somebody's skin and it gets absorbed. This is applied to the skin directly. If you get it on you, then guess what? You're going to be taking a ride too. So if it's calamine lotion, it's not that big of a deal. If it's fentanyl, that's a little bit bigger of a deal. Lotions contain the most water and are absorbed rapidly. So, if it's an ointment or a cream, it's going to sit on the skin for longer. Ointments contain the least water and are absorbed slowly. So there's some examples on your slide. If it's a lotion like calamine lotion, which my experience with that has always been for hives, itchy skin, poison ivy, poison oak, that kind of thing. We would put calamine lotion on somebody. I've never actually been called to a 911 scene to need that, but just personal experience. Hydrocortisone cream and Neosporin ointment. Let's do transcutaneous, and then we're gonna. Oh, actually, let's get through the different. Yeah, we should be done here with these in a little bit, and we're gonna take a break. Transcutaneous medications are designed to be absorbed through the skin, like through the skin, not just being done um, to fix a skin issue. The difference being those topical ointments are designed to treat something that's wrong with the skin itself. Transcutaneous medications are designed to be absorbed through it and then still get into your bloodstream to fix something systemic. Um, Also refers to as transdermal medications. So, unlike topical medications, which affect only the intended site, many transdermal medications have systemic or whole body effects. Nitro paste is a big example of that. Like I said, some systems may let you use it. Others will probably want you to stick to the pills. But these, if you touch the medication with your skin, you will absorb it, just like the patient will. All right. Your gels, this is your oral glucose. These are semi-liquid, administered in capsules or through plastic tubes. Your oral glucose is usually given through a tube. A lot of people, I've never seen anybody use the tablets, but they can. There's no reason not to. They usually have the consistency of paste or creams, but they're transparent, and in the case of oral glucose, it tastes like shit. I ain't gonna lie to you. You would think that it would taste good because it's sugar, but it doesn't. It's nasty. If you are if you're like me and you just want to, prove me wrong, then I dare you. I'll say that. Um, my advice, especially, just kind of, make it better on your patient. Oral glucose is the actual medication that you will give for hypoglycemic patients. However, if you've got a kid and you don't want to see them make the nasty face for the rest of the time you're with them and not trust you the next time you go, um, cake icing is a great example of an alternative for that, something that we use. You can also use orange juice, any kind of juice. Those are all, simple carbs, sugars that will spike their blood sugar and get them out of their situation. The contraindications are the same. They have to be awake. So, if they're not awake to swallow cake icing or orange juice, then they're not going to swallow the oral glucose either. Um, that's just some real world advice. Like I said, oral glucose is disgusting. And they even make flavored ones, but that doesn't save them. Like I know my last duty station had I think strawberry and grape, and there's no grape doesn't taste like grape. That's disgusting. It's just nasty. All right, the last one, gases for inhalation. So these are neither solid nor liquid. Usually delivered through a non-rebreathing mask or a nasal cannula. Oxygen is a gas, right? That's your easy one. Most often they're given in an operating room. So there's some other ones. Advanced EMTs can give nitrous. Okay, that's a gas. Most often, I already said that. The most common medication in gas form outside the operating room is oxygen. So when we're talking about things from the EMT perspective, oxygen is pretty much the only one you're really going to give. So if you see it on a test, that's usually your answer. Um, the only other one I've ever seen given in EMS is nitrous oxide, and that's the advanced EMT's version of pain relief. Because if you screw it up, all you have to do is just move the mask off the patient. They start breathing fresh air, and then they're out of it in a couple of seconds. They don't trust advanced EMTs to give real analgesic medication like morphine or fentanyl. That's your paramedics that are doing that. But all right, it is 7:02. Take a 10-minute break. Be back at. I'll tell you what. Yeah, this is gonna be a pretty quick chapter. Take a that's good. Take a 10-minute break. Be back at 7:12, and then we'll resume with the steps for administering medication. Alrighty, welcome back. It's been about 10 minutes, so we're going to go ahead and get back on this. Um, so tonight we're going to talk about the general steps, or at least in this section, we're going to talk about the general steps in administering medication. Jesus, I promise I'm not drinking. Medications should be administered only under the authorized use of either like online or offline med control. So some medications we can give without having to ask a doctor for it, right? If you need to give somebody oxygen, you can do that. You don't have to call. Please don't call the doctor to ask to give them oxygen. I've seen it happen, and it wasn't pretty. The other medications, though, there are some that we really do. We have the ability to give it, but we don't have the ability to unilaterally make that decision. An example of that would be aspirin, um, epi. Depending if it's an allergic reaction, don't wait. Just hit them with the EpiPen. Um, The big one is nitro. All right, because you guys, like I said, there's so many ways, so many reasons why giving somebody nitro when they don't need it or when there's a condition that stops them from getting it, it could kill them. There are paramedics that are skittish about giving somebody nitro because of what it can do to them. When they see the signs, they're like, man, by the numbers, I can give you this, but I really don't want to because I don't want to have to pump on your chest. So just kind of to remember, um, offline or indirect protocols is basically where like they've got it in writing. If they need oxygen, you can give it to them. It's 100% of the time they can write it down and you don't have to call them. Online med control is where you actually have to ask permission. That's done either with a telephone or a radio, usually with a telephone. These days, everybody's got a phone, so it's easy enough to do it. You don't have to necessarily have a radio. Um, the 6 rights, I know I said 5, they kind of go back and forth. So we're going to teach all 6 tonight. This is how to know that you're giving the right medication to the right person. So you have, and remember this, all right? You have the right patient. And EMS, that's easy, right? It's the patient that's in front of you. In the hospital, if you guys go on to be ER techs, or if you go nursing route, or ERs hire paramedics too. So you may have like 5 or 6 different patients at a time. First of all, make sure you're at the right patient. Um, don't trust names. I know some people have some horror stories about patients with duplicate names. Right medication. All right, so make sure that Bobby really needs the epi. Okay. Secondly, sorry, third, make sure you're giving the right dose. Okay, we talked about the differences in epis, the differences in ibuprofen's 800 versus a 200, that kind of thing. The right route. Okay, it's easy not to shove a pill um, in a route that doesn't make sense, but a lot of your fluids can go a few different ways. So make sure you're giving it the right route, the right time. So check the expiration date. And as far as EMS is concerned, we're really more worried about the expiration of the medication. All medications have an expiration, and depending on if it's a seldomly used medication, you do run the risk of having it expire. A lot of times your agencies will have you on the first of every month. They will have you go through and check your expiration dates on everything. And most of them, not all of them, most expiration dates are just a month and year. So when you hit the month on the first, if you see that the expiration is that month, a lot of times they'll just go ahead and remove it. That way you're not worried about it after that. And the right documentation. If you give a med, even just oxygen, make sure you put it in your report. Okay, because if it wasn't documented, then it didn't happen. Now, let's say that you give a medication, patient dies, where they're reasonably expected to do pretty well with the medication. So, like, let's say you gave some COPD patient, you gave them oxygen, but they passed away. Um, if it ever goes to court and you didn't document that you gave them oxygen, then it looks like you neglected your patient because you can say all day long, no, I gave it. Well, why isn't it in your report? So make sure you do that. And that right there, the right documentation, that is the 6th right that doesn't always get mentioned, but it should be. I'm kind of glad they put it in here. Medication errors always result from one of the following or one of the 6 rights not being followed. As long as you always do this, you'll be fine. And if it's something complex, as an EMT, you're really not going to have a lot of complex med calculations, but as a paramedic, you will. Um, have somebody else check your work. You put a decimal in the wrong place, or you're measuring out a dose for a child, but you use pounds instead of kilograms because it's 2 o'clock in the morning and you didn't really get any sleep. That matters. Okay, so have somebody look at your work. So medication administration and the EMT. That's you, by the way. Um, your unit may carry oxygen, oral glucose, activated charcoal. Good luck with that one. I usually don't see that anymore. Aspirin or epi. Um, So you're going to have to know all of these. Now, most of your epinephrine is injected, so as the EMT, you're probably not going to give it, but you do still give epi, right? EpiPens for allergic reactions. That's IM epi. You can give that. You don't have to have an IV for that. You may give these medications only according to standing orders in a protocol or a direct order. If a doctor tells you to give it to him, then you can give it to him because you're operating under his license and his authority. Um, and then your doctor that you're talking to knows what your capabilities are in your scope. So that being said, make sure that the doc that's telling you to do something is in your system, right? You need to don't just take the word of somebody that says, "Oh, I'm Dr. House" or whatever. You don't know me and I don't know you and I don't work at the hospital and I'm not your med director, but hey, give this medication. Don't do that. But if the doctor tells you, like I say, you call med control and the doctor tells you to give a medication, um, short of you finding out or you thinking that there's an error there, you can do it if a doc tells you. Over the years, EMTs have been allowed increasing responsibility to work with medications. That's why we're going to talk, whether or not it's in the slides at this point, about beta receptors, alpha receptors, and things like that, because I want you guys to understand that moving forward. You are getting more and more. When I went through, it was pretty much oxygen, and yeah, that was about it. Everything else was just assistance. A lot of the meds that we give now, I've had to learn as we've gone through refreshers over the years. Many departments have strict guidelines on when an EMT is allowed to administer a medication. Some of these are peer assisted, so you and your partner. All right, you administer medication to yourself or your partner. Let's say you got stuck in a toxic cloud, all right, and you have to give yourself a medication because of it. That's an example. Or you managed to accidentally get a certain medication on you, all right, and you've got the activated charcoal, or let's say you ingested it, you got the activated charcoal, you take it or whatever, if that's what's necessary. Um, Patient assisted administration. This is where the patient's technically doing it themselves, but you're assisting. You assist a patient with administering his or her own medication. Some examples being nitro, EpiPen, and the bronchodilator for your inhaler. You got to think about it, right? These medications are given because somebody's got a problem with their primary assessment. Their heart's messing up, their airways messing up or whatever. And as we've talked about, when the body gets to a certain level of hypoxia, you really start to experience system-wide weakness, drowsiness, that kind of thing. So somebody may be having a bad allergic reaction because they are severely hypoxic. They've got their inhaler, but it sounds stupid, but let's say they don't have the muscle strength or the muscle tone to lift the inhaler and get it to their mouth. So you can't hit it for them. They have to do it themselves, but you can assist them. You can actually help them guide their hand up to it, put the inhaler in their mouth, coach them through it, because if they're hypoxic, they may not be thinking clearly. You say, all right, inhale this, hold it, count to 10, then breathe out. That's kind of what you're doing there. You're not just unilaterally 100% you administering this medication. And then EMT administered medications. EMT administered medications, you really don't have that many, but you do have a couple. This is where you can actually give this medication to the patient, even if they're unconscious. All right, the patient may be severely confused or unable to understand the need for the medication. So oxygen is an example. Oral glucose is an example. Activated charcoal, obviously, I say unconscious, but that's a contraindication for those. But my point being is that you're not assisting. They don't have to put their hands on it. You can give this to them. Some nitros and aspirin. The medication itself does not necessarily dictate whether you will be assisting with its administration or actually administering the drug. So a lot of it just comes down to your local scope. If your med director is okay with you doing it, then they'll let you. It's kind of hard for me to tell you exactly what you can and can't give because what we can do in Mississippi is far behind the rest of the country, to be honest with you. It's just the way it is. But some places like Virginia, I want to say Washington State, they're really progressive. All right. Same thing with New York State. Arkansas is far behind. Yeah, it's funny. Your southern states typically are the ones that don't. They're a lot more strict on what you can and can't do. Your funny states like California, those are the ones that they'll let you do a lot of stuff, which is great. Um, it's really good for your patients because a lot of times you may be the first one there. Your paramedic may not show up for a while, depending on how their system is set up. All right, so oral medications. We already talked about this. I feel like we're going over slides again. We'll continue, but let me skip through some of this because I feel like we hit it. So some considerations for oral medications, your advantages, your ease of access, comfort level. Everybody's usually pretty okay with taking something by mouth. We've done it since we were kids. Some disadvantages, the digestive tract can be easily affected by foods, stress, illness. Um, it doesn't say it, but hypoperfusion can affect the digestive tract. Um, if they don't have good blood flow, if they're alcoholic, because everything has to go through the liver. So if they have cirrhosis of the liver or other, like say hepatitis, that kind of thing, that can mess with your ability to process your oral meds properly. The speed of movement of the food through the tract dramatically changes the speed of the absorption. If they are sick with some kind of food poisoning and you give them medication by mouth, it's probably going to fly through them because the body is really busy trying to get rid of whatever it is that's making them sick in their digestive tract. And you're going to pass the med real quick too. The faster it goes, the less time it has to absorb. So if you're going to give somebody medications by mouth, um, you know, there's a couple things you got to do. Make sure that they're awake. And this is anything. This is not just pills. This is your activated charcoal, even oxygen to an extent. They have to be awake for. We haven't gotten to it, but an example, since we're on this slide, is CPAP. All right, somebody's having a hard time breathing and you want to use CPAP on them, they have to be awake. They have to be able to maintain their own airway. If they don't, CPAP's got to come off. So that's an example of where even oxygen delivery has to be altered based on their level of consciousness. Instruct your patient on what they need to do. Verify your 6 rights, make sure that everything is lined up. And always, just like anything else, tell them everything that they need to know, even if you think it might be common sense. Be like, all right, ma'am, you got a headache. So I'm going to give you some Tylenol. This is such and such dose. This is pretty close to what the prescription dose is. You're going to take these and swallow it whole, and hopefully we get some relief in about half an hour. And that's important because on the flip side of that, if you show up to a cardiac patient and you want to give them some aspirin, how do most people take aspirin? Like if you were going to take an aspirin, what would you typically do? Chew it up or swallow it? You swallow it, right? Because I mean, it's like Tylenol. It tastes horrible. That's the worst. One of the oof, made that mistake as a kid. Um, but the problem is if you swallow it whole, because a lot of your aspirin have these coatings on them that slows the digestive process. It takes forever to get into their system, and we want it to act a little bit faster. But because that's not common knowledge, we have to make sure that we tell them that. So it's important that you communicate everything out loud. Don't take anything for granted. You're not talking down to your patient. You're just making sure they understand what they're supposed to do. So aspirin's a good example. If somebody's having chest pains and I'm worried about a clot or I'm worried about the workload of the heart, I'm going to tell them to here, take this 324 milligrams of aspirin, 3 or 4 baby aspirin or whatever, chew it up, and then swallow it as a powder. Don't swallow it whole. Some more oral medications. Here's your activated charcoal slide. Know this because you may see it on a test, but just also know that it's on its way out. I mean, most of your systems don't carry it anymore, just because it really doesn't do too hot. Anybody watch Fire Department Chronicles? Y'all ever see those on Facebook? So if you haven't seen them, check them out. It's a firefighter out of Florida, I believe, and he just does like comedy. Um, there was one he did where he was like, "All right, guys, we have to try all these meds before we can give them to our patients." And the activated charcoal one was funny. He's sitting there leaning up against the wall, chewing like he's got something nasty in his mouth. He's got this black stuff running all down his chin and everything, and it was activated charcoal. I love his videos. They're fantastic. He's a nice guy. Actually got to meet him at FDC once. He's or FDIC. He's pretty cool. But anyway, this is exactly what it sounds like. It's charcoal. It is straight same charcoal that's in a grill, whatever. It's just ground into a fine powder, and it's an absorbent. So if you swallow this, the concept is that whatever you swallow that's toxic to you is going to bind to this as it goes through your system. The problem is whatever you ate that's the problem is going to be way ahead of the charcoal. So by the time the charcoal gets through your system, you've probably already absorbed most of what it is that you've eaten. That's a bad thing. So it doesn't really do you any good. Activated charcoal doesn't get into your bloodstream. It just coats and runs through your digestive tract. It makes it to where whatever it was that you ingested can't get through the walls of your intestines and that kind of thing. It's administered by mouth. Tastes like crap. Usually your patients are going to try to throw it up or whatever. Don't give it to any patient with an altered level of consciousness. Just like any other oral medication, if they're altered, don't give it to them because they may choke on it. Oral glucose, this is sugar that the cells use for energy. It's the same, it's just glucose. We give it to hypoglycemia patients. Again, if you don't know, err on the side of caution and give it to them anyway. If they are hyperglycemic, obviously they don't need oral glucose, but if you don't know, you don't know. And it takes longer to have the negative effects of hyper than it does to have hypo. We put it through an NG tube if they over. That's a pretty good idea. The only problem is a basic can't give an NG tube. Um, EMTs for diabetes, this is what you give, and it's only given by mouth. Paramedics can give it through IV, well, not oral glucose, but they can give glucose in general, D10, D50. It's an IV fluid that they push, but we can't, as basics, we can't do that. It's out of our scope to give the IV. That's the reason. Don't give it to an unconscious person; they will choke on it. Aspirin reduces fever, pain, and inflammation, and it inhibits platelet aggregation. Anybody ever hear that aspirin was a blood thinner? Anybody ever heard that or assume that? That's the common knowledge for aspirin. You'll hear people say that it's a blood thinner, but it's not. If we want to get into semantics about it, which is important, we actually should at this level because you're the professional. Aspirin is not a blood thinner. It's a platelet deaggregator. What that means is it is not going to lessen the amount of platelets that are in your blood. It's what it's going to do is it's going to basically slicken them so that they can't attach to each other as easily. Um, Bottom line, you're going to have a lot of the same effects as a blood thinner, but it is not because it's not actually thinning the blood. Your body doesn't have to try to make more platelets to counteract it when it's gone. So your platelet count is still there. All right. We give aspirin for a few reasons. We give it mainly for heart attacks because it makes it harder for clots to form. If somebody's having a problem with AFib, if you've anybody has ever heard of that, if you got family members with atrial fibrillation, they're at risk of heart clots. They're clots that form in the atria and then get shoved off either into the lungs or out into the body, and that's an issue. DVTs is another one, deep vein thrombosis. We're going to talk all about this in other chapters in the medical module, but these are all reasons to give aspirin. In fact, most of the people that have these conditions, they go home, they continue with life. They're living with AFib, they're living with DVTs and whatever, and they just take an aspirin every day. It just makes it where those clots aren't as easily able to form. We do give this in heart patients whenever we think somebody's having a heart attack. Contraindications are pretty small for this. All right, hypersensitivity to aspirin is a big one. It basically is saying that if somebody's going to have an overreaction where the medicine hits them harder than it would hit somebody expectedly, we don't typically give it. If we don't know, then it's okay, just give it. But if they are hypersensitive and they know about it, then don't give the aspirin. Liver damage is a big one that we found out in the 90s. When I was a kid. I think I was in like fourth or fifth grade when Bayer aspirin started getting a bad name in the news because they were finding out that it was causing people to have ulcers and liver damage and stuff like that. And at first, they thought it was Bayer. They thought the problem was Bayer, like that company was making some bad aspirin or something like that. But as the studies came out, and they realized it wasn't Bayer. It was just the aspirin. It was that type of medication. It was a side effect that nobody had. It didn't come out immediately. Right. That's one of those long-term side effects that we didn't know about when aspirin was being tested, but now we do. So aspirin does not have a child dose. Baby aspirin does not mean that it is meant for children. All right. Baby aspirin just means it's smaller and it's a smaller dose so that you can titrate the dose a little bit better. One giant aspirin is 325 milligrams as opposed to the 81 milligrams per baby aspirin. That's the big difference there. So we don't give aspirin to kids. Sublingual medications, advantages are easy to advise your patients on what to do. Just put it under your tongue, don't swallow, right? Got a quick absorption, which is also nice because it's just a vascular area, so you're going to get it in the bloodstream pretty fast. And it's a good way for an EMT to give this without, to give something that gets into the bloodstream fast without having to worry about an IV, right? So this can be a good way for you to do something that might be out of your scope normally, but you can get around it and do something in your scope. Some disadvantages of this: constant evaluation of the airway. If they go unconscious while they're sitting there with something in their mouth, they may swallow it. That's a problem. So possibility of choking. So we want to make sure that doesn't happen. If your patient's uncooperative or unconscious, obviously don't give it to them. Like I said, that just goes with any other thing that you're going to give by mouth. Nitros. We're not really going to get into so much. Well, I'll take that back. We are going to get into it. So the thing about nitros, these are used to relieve pain in heart patients. All right, so it relieves angina pain, which is angina just means chest pain that we think originates from the heart. It increases your blood flow and it relaxes your veins. It also relaxes the veins throughout the body. That's kind of a big deal because if their blood pressure is really low and we give them a nitro, all their vasculature is going to dilate, which means their blood pressure is going to drop even more. So that's why it becomes an issue. We want to make sure that we're giving it to them right. So there's a couple things that you need to know before you even try to call med control to give a nitro. Get a blood pressure. If you haven't gotten vitals yet, at least get a blood pressure. They have to be at least 100 millimeters of mercury for a systolic. So if the top number is not 3 digits, they're not a candidate for nitro. Doesn't matter if their chest is hurting. If they're at 99 or less, they don't get it. And really, you'll be hard pressed to find a paramedic that wants to give it to them at 100 either. I mean, it's a textbook drop off point, but it really is. You can drop 30 points off of somebody's systolic if you're not careful. And then it's out of your scope to figure out whether or not they have right-sided involvement on a heart attack. But if they do, if a paramedic hooks them up to a monitor and they see on the EKG that they have either posterior or right-sided involvement, they're probably not going to give nitro, even if they do have a good blood pressure. Does anybody remember the difference between preload and afterload? Did we talk about that y'all remember in the anatomy chapter? We are going to talk about it more in the cardiac, but I want to see if you guys remember it or know it, even if we haven't gone over it yet. Nothing? Okay. Preload, afterload, Amount of blood before contraction of the heart. Yeah, that's pretty close. That can get confused with diastolic blood pressure. But so you have your preload, which is the amount of pressure pushing up against the heart to enter the heart muscle itself, to go into the right atrium. All right, so the pressure that's on the vena cavas, basically, that is your preload. That is where, when the heart valve opens to let blood in, that's the pressure that pushes the blood into the heart. All right, usually it is your diastolic. A lot of times it's pretty close to your diastolic. So that definition that Donna gave is pretty close to accurate. Afterload is the force load against which heart has to contract. Yes. Okay, good. So y'all got that. Afterload, when the left ventricle contracts, um, the pressure that's already in the aorta, because again, your blood vessels stay full all the time, right? They don't. There's no empty blood vessels unless you're having some major medical problems. Um, so the left ventricle, when the blood tries to leave it and go out in the aorta, it's got to push against the blood that's already there. That is your afterload. The reason that I point that out is, if you're going to give somebody nitro, what it does, because it dilates the blood vessels, it really affects the preload. If the blood vessels get bigger, then there's less pressure in the vena cavas because they're bigger. The blood doesn't push into the heart as easily. So if they're already having a problem on the right side of the heart, which is where the blood comes in from the vena cavas, and you give them nitros, um, even if they do have a good blood pressure, they could crash, right? That's the problem. So you as EMTs, I'm not trying to scare you. If you get you look at it, they got a systolic over 100. You've asked them their medical history. You made sure they didn't take any erectile dysfunction medications and that kind of thing. Be prepared. All right, give just in case, and the reason being is because we don't, as EMTs, have access to a monitor. There's no way for you to know if they have a posterior MI or a right-sided MI, which is the preload side of the heart. Um, and they and people know that, right? The people that make the rules, they know that. So if you give a nitro, I'm just telling you that just because they have a good blood pressure doesn't mean that they won't still crash if that happens to be the case. So just be ready. Something else to be ready for. Your patients are never gonna they never seem to understand this. Even if they're prescribed nitros, they don't seem to get it. It can cause a headache. The sudden dilation of blood vessels affects the cerebral blood vessels as well, which can lead to headaches. That's just a normal side effect. There's a couple different ways to give it. So we give a tablet, which can be sublingually under the tongue. You really don't want them to just swallow it. You're not trying to give it to them through their digestive tract, because again, the digestive tract operates very slowly. So even though a lot of this is going to go into the mouth, it's not the goal to swallow it. The goal is to put it either up against the cheek or under the tongue or something like that, so that it gets absorbed into the bloodstream pretty quick. If you're going to give it by a metered dose spray, you're going to either spray it on or under the tongue. And the general dosing, one spray equals one tablet. So if the doc tells you to give up to 3 tablets, and you have spray, it's up to 3 sprays. All right. So the administration considerations, again, just to recap it, because this is important. Wait 5 minutes for a response before repeating the dose. We talked about it when we talked about patient assessment. If they're unstable, how often are we going to reassess their vital signs? This is an easy way to remember this. 5 minutes. Every 5 minutes, we reassess vital signs on an unstable patient. Any heart patients, even if they look fine, they're sitting up talking to you, I just go ahead and consider them unstable, because we don't know what if they're having a heart attack or not. So when you give nitro, give them 5 minutes, let it take effect, and then check them again, and figure out from there whether or not they need that second or third dose. Closely monitor the patient's vital signs. You should check their blood pressure before every pill you give. The first pill, they might have been at 120. Oh, great. You can give them a pill. That one knocks them down to 99. The second pill, if you don't check the blood pressure and catch that, can kill them. So make sure every dose, you can give up to 3, but treat every dose as its own intervention. Don't look at it as like dose 2 or dose 3. All right. So you're going to go through all the checks again. Wear your gloves, especially if you're giving it via spray or something that's absorbed. You should be wearing gloves anyway, but just keep that one in mind. And then know your local and state protocols, the ones that actually govern you, just because different people have different agencies have different rules on who, like what you can give. All right, intramuscular medications. These are getting into EpiPens is pretty much the thing that you can give. So quick, easy access without using a vein. This is great, and you don't even have to really expose the skin on a lot of these. Stable blood flow to the muscles. Your muscles are very, very vasculated. They have to be because think about it, you move a lot, right? So you're operating those cells. You need to have a good blood flow. So going into the muscle is a good way for you to get a blind stick in somebody when time is really of the essence. You're not worried about catching a vein. You're just trying to have them not die on you. Disadvantages of this are use of a needle. So it's going to hurt them a little bit. So you feel going to pinch, but you also run the risk of stabbing yourself. So that's the important thing here. The medication that we give in IM is your EpiPen, which is epinephrine. You stab yourself, you're going to be the one that's off to the races with the vital signs. And your patient may fear pain or injury. I know grown men in the military that pass out at the sight of a needle. So keep that in mind too. All right. Epi controls your fight or flight. Basically, it's going to do a couple of things. It's going to raise your pulse. It will raise your blood pressure a little bit. It's a vasoconstrictor, which is why it raises your blood pressure, and it's a bronchodilator, which is why we give it for asthma, not asthma, I'm sorry. We give it for allergic reactions. When somebody has an allergic reaction, we're going to have a whole chapter devoted to this. We're mostly concerned about their airway because the body, in trying to fight whatever it is they're having the allergic reaction to, is going to try to dilate their blood vessels to get more blood flow um, to the area that's got the toxin and try to flush it out. Problem is the chemicals that do that, your blood vessels and your airway operate in tandem with each other as opposites. So if you constrict the blood vessels, you're going to open the airway. But if you dilate the blood vessels, you're going to constrict the airway. The body's not trying to choke itself out. The body's trying to dilate the blood vessels, but that's a side effect of your adrenaline, or I'm sorry, a side effect of your histamine. So your allergic reaction response is caused by histamine being dumped into the blood. It causes your blood vessels to open, but it constricts your airway. If it's a bad enough allergic reaction, it will completely shut your airway off. And that's where the problem comes in. So the opposite of that is adrenaline, or in our case, epinephrine. We pop somebody in the muscle with this, and it has the opposite effect. It constricts their blood vessels, but the side effect of it, which is in this case, it's a side effect of epi, but it's what we're actually wanting to do, is it will dilate their bronchos. So it's a bronchodilator, a vasoconstrictor. All right, all this is pretty much saying the same thing. Don't give it to patients with hypertension, because it's going to make hypertension, being high blood pressure, is going to make bad situation worse. The problem with hypothermia is it doesn't flow through the body very well. Your blood flow is not where it needs to be. A lot of times your skin doesn't have the blood flow, so if you pop them with it IM, it's going to sit there and it's not going to get picked up by the bloodstream. Um, let's see, maybe developed or maybe delivered with an auto injector to treat life-threatening anaphylaxis. That is your EpiPens. That's how we're going to use it. Your higher levels of care can give it through an IV, but we don't as EMT basics. And then this is just going into why we would give it. Histamine responses, allergic reactions. I will say this again. We're going to talk about it in the allergies chapter, but EpiPens a lot of times come with 2 doses now. So when you pop somebody the first time, don't just throw it away. Epi wears off in about 2 to 5 minutes. So a lot of your EpiPens now come with a second dose just to kind of extend that if they need to. Because if the allergic reaction is bad enough, all those histamines will still be in the system when the Epi wears off, and then they fall right back into it, so you can hit them with that second dose. All right, intramuscular medications. The last one we're going to talk about is naloxone. So as EMTs, you can give this through IM or intranasal. It's really just kind of up to you. It's up to your agency, whatever they order. So this is used to reverse the effects of an opioid overdose. We already talked about how it does that. It competes with the receptors that the opioid is using. So if, like I said, be it intentional or accidental, if somebody has an opioid overdose in their system and you hit them with naloxone, it's going to bind with the receptors more easily than the opioid will. And so it'll do it faster. And then now that opioid can't attach and their body doesn't adjust to it anymore. There is one thing that I want to say though, before you hit somebody with naloxone or Narcan or whatever you've got, we tend to only give this to stop them from going into respiratory arrest. We're not trying to wake our patients up. In fact, when you do wake them up, it doesn't always work in your favor. There's videos on YouTube and it's been in the news where, a good Samaritan with Narcan saw somebody passed out in the street, ran up to him and hit him. Didn't know it was opioid, just took a guess. Hit him with the Narcan. Turns out it was opioid, and they woke up and then proceeded to beat the living Jesus out of this good Samaritan. And the good Samaritan guy winds up in the hospital fighting for his life because somebody whooped his ass. Basically, I mean, when you come out of a hit, you come out of an opioid overdose, you feel like you got ran over. Your patient is going to be hurting everywhere. They're not going to be happy. And if they are still under some other effects of whatever else they took, you could be in a very dangerous situation. So don't give somebody naloxone as an attempt to wake them up. We do that so they don't go into respiratory arrest because I don't want to do CPR on anybody if I can help it. That's why it says consider your safety. All right, so intranasal naloxone again. The most common technique for this is intranasal. It's easy. You just take the medication, you screw that atomizer on it, which is the little cone-shaped thing that you see in that person's nose. And when you push the medication, it diffuses it into these tiny, tiny droplets that are small enough to get absorbed by your bloodstream. So it's not like you're just shooting a spray of liquid up there. For inhaled medications, oxygen is your big one. This is by far the most commonly administered medication in the pre-hospital setting. We get it with every breath. Like I said, regular air has 19%, as long as it's normal. There's no toxins, nothing that's displacing it. 19% or 19.5, if you want to be specific, is right where room air is. We do give it at higher percentages if we need to, but even if you can't give it to somebody, they're going to get enough. They only need 19% to be fine. In the emergency setting, the non-rebreather mask is our preferred method because you can give them a better quality of oxygen, get a higher percentage. But in the interest of not putting somebody over 100%, we usually stick with the cannula. These slides haven't been updated to that. It used to be you only went with the cannula if your patient was claustrophobic and they had a problem with the mask. But now, unless you really do need to give them an abundance of oxygen, you can just go with the cannula. Meter dose inhalers and nebulizers are used to administer liquid medications that have been turned into a fine mist by a flow of air and oxygen. If you work with a paramedic, this is how they usually deliver albuterol treatments to asthma patients or COPD patients, that kind of thing. What they'll do is, if you look at this picture, the little compartment at the bottom, they'll put the medication in there. Sometimes if it's a child, they'll put some saline in there as well to kind of dilute it. Screw the lid back on there, and then they'll turn on the oxygen. Oxygen flows through the tube, and it causes the medication to bubble and boil, and so it comes out as a mist for the patient to breathe. All right. For these inhalation medications, it's that talk right there about a spacer. You can see it in the picture on the right. Spacers are typically used for kids who aren't very good with their inhalers yet. What that does, and you have to understand this as an EMT because you assist people with this. Um, what happens is they will spray the inhaler into the spacer and it kind of hangs out there, and then they will suck on the other end of that spacer to pull the medication into their mouth. Um, That's all it is. It's just like a holding tube. It takes away that pressurized push that somebody might get if they put their mouth directly on the inhaler. So it's easier for kids. That's why it's especially useful with young children. It just makes it they get it in their into their system easier. Um, Nebulizers, I was just talking about that on the previous slide, so I'm not going to go into it. You can use nebulizer with CPAP and during BVM ventilation. You just sometimes, depending on the equipment you've got, and we'll show you some tricks you can do at the boot camp, but you may have to do some unofficial alterations to make a non-rebreather work with a nebulizer or something like that, depending on how bad the condition of your patient is. Like I said, we'll show you those tricks. Those aren't condoned by the manufacturers of the equipment, but they work. All right, let's see. We already touched on everything on this slide, so we'll move on to the next one. Patient medications. Your patient assessment includes finding out which medications the patient is currently taking. It's not just what they took, but also what they're prescribed, because just as important as what they took is what did they forget to take, right? Um, but when you're the one that's wanting to give a medication, it's very important to know what they actually have in their system. So this information may provide vital clues to the patient's condition. It'll help you with your treatment. The example that we always go back to is erectile dysfunction pills, because they will preclude you from giving nitros. And normally, everything else about that call screams, give this guy nitros, but you can't because he took Viagra. And keep this in mind too. Some of those new erectile dysfunction pills that are in use today, they can last up to, I think, 48 hours. Their time release for like up to 2 days. So, first of all, the 50-year-old guy is not going to want to tell you that he took Viagra. It's going to be like the 15-year-old girl telling you that she's sexually active. They don't like doing that. So you have to let them know, be like, hey, I understand, I get it, but I need to give you a medication that if there is an erectile dysfunction medication in your system, this could kill you. All right. And like it could make the matter a lot worse. It's okay if you took it. I just need to know so I don't give you this med. Um, and document it. Because especially if you give it to them and they crash, chances are they lied to you. So make sure you put that in your report. Don't write down the patient lied. Just put in the patient stated no erectile dysfunction medication. Vital sign was this. Had permission to give it from med control. Patient still crashed. And it could be a couple things. It might be that they had right-sided involvement, right? We talk about, like I said earlier, the right side of the heart gets affected. The medication, the nitro, will hit them a lot harder than what we expected to. But anyway, getting this information is extremely useful, not just to you and what you can do, but it's very useful to the emergency department as well, because a lot of medications that they give are longer lasting. They're out of your scope, they're out of your med bag. Even your paramedic doesn't carry it, but they still have drug interactions. They got to know about it. You may not be able to get it, especially if a patient is unconscious, but if you can get that information either from them or from somebody else, it always benefits you and the patient to do so. Okay, medication errors. This is unfortunate, but it does happen, and the consequences are very steep. Nurses lose their jobs all the time. I think that the average, if they find out that your med administration was through negligence or whatever, something like a $10,000 fine and the unemployment office. It's pretty steep. So make sure that you don't get complacent and start skipping those 6 rights, 5 rights, whatever you want to say about it. That's important. That's what's going to keep you from doing these things. If you move on to a position where you are doing med calculations and stuff like that, absolutely use a calculator. Absolutely use your partner. Let somebody who knows, like you do, look at that and say, yes, that looks right. And if it doesn't, say you do a med calculation, or your paramedic does a med calculation, and they pull up a drug, even if you don't know the numbers, if they pull something up and it just by the quantity of the liquid looks like it's just not right, say something. Even if it is right, even if you don't know, if it doesn't look right, if all you did was cause that paramedic to go back and second guess and double check, then great. So a medication error is an inappropriate use of a medication that could lead to patient harm. Anything that goes wrong in this could include incorrect communication of a dose, and it may not even come from you. It may be that the doctor told you the wrong dose because he's too busy. So again, I don't want to scare people. And I hate that because this is kind of the fear mongering portion of the chapter, but it's just very, very important. Um, you don't have to memorize everything, but the more you go through your career, the more you're going to start to know what the dose is. And somebody tells you something that doesn't look right or doesn't sound right, call them out on it. Be like, hey, are you sure you want me to give this amount of this med? Just like a little while ago, we were talking about epi, and I got the ratios backwards. I said we put 1 to 1,000 in somebody's bloodstream, that would probably kill the patient. Um, I know it's supposed to be 1 to 10,000, but when you get distracted, sometimes you say the wrong number. So even your doctors are not perfect. If you hear it and it's weird, doesn't sound right, say something. Couple of other reasons, you have rules-based errors. So administration of medication is outside of your scope. And like I said, EMTs can't give IVs, so you can't obviously give a medication by an IV. Knowledge-based error, which is where you just choose the wrong medication, you didn't know any better. And then skills-based errors, which is where you use the incorrect equipment or the incorrect procedure for administering that medication. If the circumstances of medication errors are understood, hopefully that'll stop you from doing them, but that doesn't always mean that you will be flawless. It's just try to, as long as you do the best you can, if you do make a mistake or if you don't catch a mistake from somebody else, that due diligence was there. And so, as unfortunate as it is, it still protects you. You're at least covered by that. So, if a medication error does take place, rapidly provide any appropriate care that you can. Notify med control as quickly as possible so that if they need to get another team in place at the ER for when you arrive or get some medication drawn up so they can hit the patient right when you roll in the door, they can go ahead and get prepared for that. Follow your local protocols. There will be documentation your agency has on what to do, not just for your patient, but also for you. So, like an accidental stick, or you get fentanyl patch on you. You know, you got it slipped and it hit your wrist or something. Make sure you document everything, and then talk with your partner, your supervisor, or your med director about what happened because this is a great opportunity to learn so you don't do it again. And it helps identify areas, especially if it wasn't your fault. Not every med administration area is going to be your fault. So, talking this over with coworkers helps you to identify processes that may need to be improved. Like, well, this didn't work right because we suck with the nitro paste, so let's switch to the spray or let's switch to the pills, that kind of thing. All right, guys. Well, that was short. Okay. So I do want to talk about something before we call it a night because this wasn't in the chapter. We're going to talk about we early on we talked about agonists and antagonists. So I want to talk about medications and how they affect certain systemic body functions because when we get into things like cardiology, this is going to matter. So we have alpha and beta receptors in our body. All right. Easy way to think about that. Alpha affects your vascular systems, your arteries and veins. So to me, when I was learning this, I said alpha starts with an A, so does arteries. That's how I knew that. Some medications are designed to affect that. Not necessarily what you would give as a basic, but your paramedic is going to give some. Atropine, for example, if you've ever heard of that drug, that affects somebody's alpha receptors. And then for beta receptors, it's broken into two, and they're pretty easy to remember. You have beta 1 and beta 2. You have one heart and two lungs. So a beta 1 um, medication affects the heart. So like epi is a beta 1. Give me a second. Oh, got it. Perfect. Okay. Oh, sorry, I had to sneeze. Beta 2 is your lungs. So any medication that's a beta 2 agonist is going to be something that affects your lungs. An example of that would be um, albuterol. Yes, beta 1, you have one heart. So one heart, two lungs. Beta 1 is for your heart. Beta 2 is for your lungs. Now, a couple of things I want to point out, some examples of this. If you ever hear about somebody being on a beta blocker, anybody know what a beta blocker is? Okay. So beta blockers, the reason that we give them is that we try to stop the heart from picking up the pace. If you or if you have a heart patient, or if you yourself are a heart patient, they don't want your heart to work too hard, they'll give you a beta blocker. That is a beta 1 agonist or antagonist. I'm sorry, it's a beta 1 antagonist. So it's like the opposite of epinephrine. Um, what it does is it creates an environment where the heart is unable to act on stimulus that's put into it. So if somebody is a beta blocker overdose, their pulse is going to start to drop. Um, if the body is operating too much under an antagonist, we give an agonist to fix it, and vice versa. If somebody has overdosed on beta blockers, the response typically is going to be to give them epi. So keep that in mind. If and what you'll see as an EMT, especially with beta blockers, is you'll be checking out the vitals of your patient, and you're expecting the way that their blood pressure looks, the way that everything else looks, or even just their condition. You would expect them to be tachycardic. Um, but if they're on a beta blocker, they're not going to be. And it's because the medication is holding them back. When their pulse should be picking up, but it can't because that medication is there. Um, when it's used properly, it keeps their heart rate at a pretty good steady beat, like 60 beats a minute. Sometimes, especially elderly, when they forget what meds they took and they, decide they want to take it again, maybe because they're hurting or whatever, they just like, well, I need to take my meds, and because I'm hurting, I must not have taken them today, so I'm gonna take them again. They do run the risk of overdosing, and some people do it intentionally, but keep that in mind if something's not making sense. They can get to the point where the beta blocker is so potent inside their body that their heart rate just crashes out. As EMTs, there's not a lot you can do, but it's important to understand what those are and what those terms mean. All right, because you may actually see questions about that in your test. I don't know why it's on the slides, because I know that the last class they did have some questions about alpha and beta receptors and how those worked. And if you go on to be a paramedic, you really have to know that, because you may encounter a patient that's on a certain receptor agonist or something, and knowing what that means lets you know what medication that you need to give. But otherwise, that's going to be it. I'm not going to go too off into the weeds on alpha and beta receptors, other than I just wanted you guys to know round about what they were and what that meant. So just remember, moving forward, alpha receptors have to do with your vasculature. So A for alpha, A for arteries. You have one heart, two lungs. So beta 1 is for your heart, beta 2 is for your lungs. Your pin for the night is going to be C11 or C11. PH. C as in Charlie, 11, P as in Papa, H as in Hilo. There you go. Crystal Davis and Megan got it typed up. Appreciate y'all for that. Because my computer doesn't like to type into that text box for some reason. Any questions on tonight, on anything up till tonight? Somebody had a question for me this morning, and I'll tell you what, before y'all hop off, or before I stop the recording at least, I'm going to put this in. It was a great question. I didn't get a chance to answer it. Here we go. So cardiac output measured in pre-hospital care, or do we just need to understand proper ventilation so we don't mess up the output? So excellent question. In EMS, we can't really measure cardiac output and minute volume or stroke volume or any of that stuff in the field. We get a best guess for it, okay? But we have no way of actually measuring that. There's not enough information in what you can get in your assessments for that. So the reason that we teach it is so that if you look at somebody's vital signs, you can understand the context of why is it 12 to 20 breaths a minute that's normal for an adult. Why would it not be normal, or why would there still be a problem just because somebody's breathing in that range, but it's still going to be red flags for you? It's because they're not breathing adequately. You don't see a good chest rise and fall. So it's not so much that we need you to know. I want you to know how we get stroke volume, how we get minute volume, and all of that, cardiac output, as far as like what it is. So know the equation. But when it comes to actual skills, it's more of a knowledge of just what it is, and that we're hoping that the vitals, the breaths that somebody's taking are deep enough. The heartbeat that somebody's got is good enough contraction, good enough reload, cardiac reload of the heart where it fills back up with blood so that each beat is giving a good amount. That was a great question. I didn't get a chance to answer it earlier. Anybody else? Anybody have? You're welcome, buddy. Anybody else have a question? Nothing. All right then. Um, I haven't looked at your grades. If you still have tests to do for Module 1, get those done as soon as possible. We're pretty much I'm going to give you guys till the end of this week to finish Module 1. After that, the grade you got is the grade you got. So hopefully it'll be a 75. And then Module 2, this is the last chapter of Module 2. So go ahead and get your Module 2 test caught up. I'm going to give you guys until the next lecture, which is Tuesday, to complete it. So you have through the weekend to study, ingest this chapter, take your module test, everything will be fine. Remember, you guys, if you do mess up, you get 2 attempts. You just have to let me know so I can go in and unlock your second attempt. But other than that, y'all have a great night, and I'll see you on Tuesday.